My name is Dr. Surbhi, Junior Resident, Department of Psychiatry. Today, I'll be presenting my seminar on the topic of delirium and organic mental disorders. We'll be covering the topic under these broad headings, wherein we'll be talking about the organic mental disorders, types of organic mental disorders, a little bit detail of delirium, dementia, amnestic disorders, organic mood disorders, organic psychotic disorders, followed by summarizing the whole seminar and references. Now, what are organic mental disorders? Organic mental disorders, also known as organic brain syndrome, refers to psychological or behavioral disorders that are caused by identifiable physical or physiological damage to the brain. These disorders result from clear organic cause such as injury, disease, or chemical imbalance rather than purely psychiatric or emotional origins. Now, today we have gathered as for the sake of Lysian medicine, wherein psychiatry residents as well as emergency residents have gathered here for the seminar. So this becomes a very crucial point. Residents and even psychiatrists, as emergency medicine experts, it becomes important for us to rule out whether the patient falls under the organic mental disorders or patient falls under the category of disorders. So, following the two classifications, ICD-10 and DSM-5, we can broadly classify the organic mental disorders under these headings. First is delirium, wherein ICD-10 quotes it as F05, wherein delirium, which is not induced by alcohol or other psychotropic substances. And DSM-5 directly calls it delirium. Dementia, which comes under the category of major neurocognitive disorder, and wherein it falls under the categories of F00 to F03 in ICD-10 criteria and major neurocognitive and disorders in the DSM-5. Mild cognitive disorders में F0 6.7 में आता है in ICD-10 and DSM-5 says it directly mild NCD. Amnestic disorders are covered under the coding of F04 or other substances, and amnestic disorders now, which are under the major or mild NCDs due to another medical condition, is covered under in the DSM-5, and other hallucinosis, delusional disorders, mood disorders, and etc. Now, types of organic mental disorders. So there are four broad categories: delirium, dementia, amnestic disorders, organic mood disorders, and organic psychosis. Now, what is delirium? This is something which is encountered very commonly by the psychiatrists as well as the emergency resident, as the emergency medicine experts. So in medicine, delirium is an acute, often sudden change in mental status that causes confusion, disorientation, and difficulty with attention and awareness. It can be caused by illness, medications, infections, or withdrawal from substances. Now, as we will furthermore succeed in the seminar, we'll understand the causes of delirium and how are we supposed to proceed with the patients who have delirium. Before that, starting with the case snippet. So, Mr. M, 78-year-old female, Mrs. M, 78-year-old female, was getting treated for urinary tract infection from 2 days. She has a history of hypertension and mild cognitive impairment, but was previously alert and oriented. Then she presented to the emergency department on the second night of the OPD treatment with the complaints of sudden confusion and agitation, became disoriented to time and place, tried to leave the room, was talking to people who weren't there, and became agitated, pulling out her IV lines. Clinical findings: her vitals were temperature was 38.3 degrees Celsius, heart rate was 98, blood pressure was 130/78, mental status examination, there was fluctuating level of consciousness, poor attention span, disorganized thinking, unable to recall the date or location, and neurological examination dealt with no focal deficit. So this case snippet, what do we come to know from this? So therein, looking at the presenting complaints, we come to know about sudden confusion and agitation. So the onset of illness is sudden. Then there is disorientation present. Along with that, it is also mentioned that she was previously alert and oriented. And another clue point here is the urinary tract infection. So, now talking about the causes of delirium, first are the medical illnesses in which infections are actually the most common cause of delirium, out of which urinary tract infections hold the greatest chunk. Pneumonia, sepsis, meningitis, encephalitis. So whenever we come across patients with these illnesses, we have to rule out delirium and we have to make sure that the patient doesn't become delirious. Metabolic and systemic disorders में electrolyte imbalance are known to be very notorious. Thyroid disorder. Medications and substance-related causes, drugs, especially in the elderly. So any elderly who's on anticholinergics, who's on benzodiazepines, opioids, corticosteroids, or polypharmacy, they are susceptible to delirium. Drug withdrawal, wherein alcohol tremens is the most notorious one, benzodiazepine withdrawal, hypnotic withdrawal. And drug intoxications, alcohol, narcotics, hallucinogens, or other toxic substances. Neurological causes, stroke or transient ischemic attack, head trauma or concussion, brain tumor, seizures or post-ictal states. Environmental and situational factors may prolong hospitalization, wherein we use this lay term a lot, which is ICU psychosis, which is also why it is so common. Sleep deprivation is another reason. Sensory deprivation or overload, so no glasses or hearing aids. That is why we always say that the elderlies, they should be deprived sensorily. Pain, immobility, or use of physical restraints. Risk factor or predisposing conditions, advanced age. Any elderly coming to the emergency, we have to rule out delirium. Pre-existing dementia or cognitive impairment, poor vision or hearing, delirium, and severe illness or surgery. Now, to conclude with delirium, another case. Patient 52-year-old male, long-term alcohol use, drinks daily from about 15 years, presented with stopping the drinking pattern from past 2 days, now experiencing confusion, tremors, visual hallucinations, seeing insects on the walls, sweating and agitation. And looking at his vital signs also, his blood pressure is quite raised, heart rate is also raised. Tremorlessness is present, disoriented, unable to follow commands. Diagnosis is delirium tremens, which is severe alcohol withdrawal, typically 48 to 72 hours after the last drink, which is something wherein we psychiatrists deal with this case scenario a lot. Now, how are we supposed to manage delirium? First of all, it becomes crucial to identify and treat the underlying cause. The first step is to find and address the root causes of delirium. Common triggers include infection, medications, metabolic imbalances, organ dysfunctions. The goal is to correct these issues promptly. Common causes and interventions. So infections may administer appropriate antibiotics or antivirals. Electrolyte imbalances may we have to correct the electrolyte imbalance. Medications, we have to discontinue or reduce any sedatives, anticholinergics, or other drugs that may be contributing. Metabolic causes may treat underlying conditions like hypoxia, hypoglycemia, hepatic encephalopathy, or renal failure. Substance withdrawal, administer medications to manage withdrawal symptoms. Then, coming to the supportive care. Now, it is very important for us to understand that delirium is more so of supportive care only. The first line and the major line of treatment is supportive care in delirium. So it becomes important for us to make sure that we are trying to reorient the patient. Even if we are dealing with the patients, we try to ask their family members also to install large clocks, to install big calendars in the room, to actually talk to them, to keep on reorienting them after a certain point of time again and again throughout the day. So use clocks, calendars, familiar objects to help orient the patient. Family or familiar caregivers should be encouraged to visit regularly. Comfort and environment, minimize noise, avoid physical restraints, and ensure adequate lighting during the day or the night cycles. A quite well-lit environment is important for minimizing confusion. Encourage mobility. Help the patient sit up and move around is tolerated to prevent further confusion and deconditioning. Hydration and nutrition, ensure proper hydration and nutrition, as dehydration or malnutrition can exacerbate the delirium. Benzodiazepines. Indicated for delirium due to alcohol withdrawal, wherein we use lorazepam, diazepam, and chlordiazepam oxide is also used. Avoid in cases of other causes of delirium as they can worsen cognitive impairment and confusion. Because we had read it in the causes also that benzodiazepines are notorious to cause delirium as well. So they are only and only used in alcohol withdrawal. Antipsychotics. Second generation antipsychotics like risperidone, olanzapine, they are often used for severe agitation or psychosis associated with delirium. Haloperidol, which is the first generation, is commonly used but should be prescribed cautiously in elderly patients because of the risk of extrapyramidal side effects and QT prolongation. Risperidone and olanzapine may be preferred due to lower side effect profile. But still, you have to be very careful with these patients for extrapyramidal side effects, especially the patients who have already have Parkinsonism or any movement disorder. Then, talking about the preventive measures, it is always better to be preventive as far as figuring out cure for a modality is concerned. So, how are we supposed to prevent delirium? First of all, we have to minimize the use of restraints. Now, this is a very important point wherein we feel that we should restrain the patient, take a proper written informed consent, but we should try to avoid it as much as possible because it can actually increase the agitation and confusion. So you use them only as a last resort, preferably non-physical restraint like bed alarms or sitters. Avoid any invasive procedures, minimize the use of catheters, IV lines, or other invasive devices, as they can increase the risk of infection and contribute to confusion. Nighttime orientation. Use light therapy or other techniques to help the patient distinguish day from night and reduce sundowning. Sundowning is an effect which is seen in delirium patients. So you will see that the fluctuation in their orientation will be more profound in the evening hours as compared to in the day hours. So that effect is known as the sundowning effect. Addressing family and caregiver needs. It is very crucial, very important to psychoeducate the family members, to psychoeducate the caregivers. So education, inform the family and the caregivers about the nature of delirium, its causes, and how they can assist in the patient's care. Emotional support. Offer counseling or emotional support to help the family members cope up with the stress of loved one experiencing delirium. Because delirium is in itself a very stressful situation to experience also, to witness also. So therefore, the family members also require an emotional support. Monitoring and follow-up. Frequent reassessment, monitor the patient's mental status regularly, especially during the first 24 to 48 hours. So in our case, we apply serial MSCs. We do their serial MSCs every 24 hours, we repeat that, and we document the serial MSCs. Multidisciplinary team, a team of doctors, nurses, physical therapists, and the other specialists should collaborate to manage both the delirium and its underlying cause. Post-discharge care. Provide proper follow-up care, especially for patients at high risk of recurring delirium, like the ones who are elderly, those who have dementia and any other cognitive ailment. Ongoing cognitive support and rehabilitation may be necessary. Now, what is the prognosis? If the underlying cause is treated promptly, delirium can be reversed and the patient may return to their baseline cognitive state. However, delirium in the elderly or those with pre-existing cognitive impairment may result in lasting cognitive decline or increased risk of mortality. So it is very important. Though people feel that it is reversible, so they don't care that much about delirium, but we need to understand that there is always an increased risk of mortality. The delirious patient, especially the patient who has a history of delirium, especially a patient who has a history of any complicated withdrawal, especially a patient who is elderly. Delirium is a medical emergency requiring prompt recognition and intervention. Treatment focuses on identifying and addressing the underlying cause, providing supportive care, and using medications judiciously when needed. Prevention and early intervention are critical to improve outcomes and reduce the risk of complications. Now, talking about the second one, which is dementia. Dementia is a chronic progressive syndrome, which is characterized by decline in cognitive function like memory, reasoning, language, judgment, and behavior, severe enough to interfere with daily life and independence. Unlike delirium, dementia develops gradually and is usually irreversible. Now, what are the features of dementia? There's memory loss, which starts with early short-term memory loss, wherein the patient will start losing memory of the things that they've done in a very shorter span of time. Language problems will be there. There'll be difficulty in finding words and forming sentences. There'll be disorientation, confusion about time, place of familiar people, poor judgment, inappropriate decisions, risky behavior. A lot of dementia patients, they actually go on the railway tracks, they go on the roads, so they don't understand what are they doing, where are they, posing their life in danger. Personality changes, mood swings will be there, irritability, apathy, and depression. Impaired daily function like difficulty in cooking, handling money, dressing up, etc. Now, what are the types of dementias? There is the most common one is Alzheimer's, which is the most common. Memory loss is first, and then there it gradually progresses. Vascular dementia, there's a stepwise decline, and it always has a temporal correlation with stroke or poor blood flow. Lewy body dementia, here it is very notorious for visual hallucinations and Parkinson's-like symptoms and fluctuating cognition. Visual hallucinations most commonly seen are of the snakes. So patient will say that I can see the snakes crawling over the roof, on the ground, on the walls, everywhere. Frontotemporal dementia, as it is said, fronto. So frontal lobe and temporal lobe, which are responsible for a personality and behavior. So there will be early personality and behavior changes and speech problems. Mixed dementia, wherein there's a combination of vascular as well as Alzheimer changes, and Parkinson's disease dementia, wherein the motor symptoms will be the first one to occur, followed by the cognitive decline. How do we diagnose dementia? So clinical assessment में history from the patient and family, mental status examination, wherein we can apply either MMSE or we can apply MOCA. And then we have laboratory tests to rule out reversible causes like B12 deficiencies, thyroid disorders, or any other thing. Imaging, CT and MRI to assess the structural changes, strokes, and tumors, or any space occupying lesions per se. Neurophysiological testing with detailed cognitive evaluation where diagnosis is unclear. Pharmacological treatment. Though it is irreversible, none of the modalities have been FDA approved, been discovered or invented which can actually treat or manage dementia. But these modalities are somehow, they are responsible for plateauing the effect of forgetfulness, or they somehow plateau the progression of dementia. So cholinesterase inhibitors like donepezil, rivastigmine, or galantamine, they're used for mild to moderate Alzheimer's. NMDA receptor antagonists like mementin, which is used to moderate in severe stages, and antidepressants and antipsychotics for mood or behavioral symptoms. Non-pharmacological intervention. With patients in geriatric psychiatry, basically, non-pharmacological interventions pose a as compared to the pharmacological interventions. So cognitive stimulation therapy, we can always go for routine and structure in daily activities. You can make a timetable, give it to their caregivers and ask them to repeat the same timetable again and again. Do not make changes in those timetables. Physical exercise and healthy diet is very important. Environmental modifications to improve safety, like grab bars, labels, lightening the ceiling and the flooring. So everything like that. Support for the caregivers, education about the disease progression, respite care and community support, legal and financial planning, like power of attorney, advanced directives. So this comes under the forensic psychiatry. Now, reversible causes that mimic dementia. Whenever a patient will come to us with the history of which will be painted like a patient of dementia, so it becomes important for us to rule out, especially in the emergency setup, it becomes important for us to rule out depression, hypothyroidism, vitamin B12 deficiency, normal pressure hydrocephalus, and brain tumors. Now, patient with confusion has landed up in the emergency. Now, here is what the history. Here's the history is going to play a very crucial role. So we will try to determine the onset, whether it is hours to days or it is gradual onset or not. So if the onset is sudden, which is within hours or days, then we will check for the fluctuating symptoms in attention and hallucination. If it is present, then it is likely delirium. Then we have to search for the acute cause of delirium. Then, if the onset is not sudden, it is gradual, decline in memory and cognitive functions over months and years, then it is likely to be dementia. And then we have to access the type of dementia and then furthermore move about it. Then, talking about the amnestic disorders. Amnestic disorders are characterized by significant memory impairment without major deficits in other areas of cognitive functioning, like reasoning or attention. These disorders involve problems with learning new information, anterograde amnesia, or recall of the past events, retrograde amnesia, and are usually caused by organic damage to brain structures involved in memory. The definition is very important because it is only through the definition that we will be able to differentiate between dementia and amnestic disorders. What are the features? Again, impaired memory yahan bhi hai, but there is inability to learn new information or recall past events. Whereas in dementia, there will be a very gradual progression. It will start with new information and go to past events, wherein it will be very haphazard. Preserved attention. Unlike delirium, attention and awareness are usually intact, no major intellectual decline. Other cognitive functions are relatively preserved, wherein in dementia and delirium, the other major cognitive functions were also declining alongside. Possible confabulations, making up stories to fill the gaps, common in Korsakoff syndrome. Very commonly seen, these people are very beautiful story makers. They'll make a story which will actually look like a true one, sometimes and sometimes not. Significant functional impact interferes with personal, social, or occupational life. Now, what are the causes of amnestic disorders? First and the foremost one, which is quite commonly seen with us psychiatrists, is thiamine deficiency. Common and chronic alcoholics leads to Wernicke-Korsakoff syndrome. Head trauma, another very common reason, can cause post-traumatic amnesia. Stroke affects memory-related brain regions like hippocampus. Brain tumors, especially the temporal lobe or diencephalic structures. Hypoxia, brain damage from lack of oxygen. Infections like herpes simplex encephalitis, neurosyphilis, or HIV. Neurodegenerative diseases in early stages of Alzheimer's or other dementias. Diagnosis, clinical history, focus on the onset, duration, and associated factors. Cognitive assessment through MMSE, or we can also go for Wechsler memory scale. Neuroimaging, MRI-CT to identify any structural damage, lab test for thiamine levels, vitamin B12 levels, infections, or metabolic disorders. How are we supposed to approach these patients? First of all, very important for us to treat the underlying cause. Thiamine for Wernicke-Korsakoff manage infections, oxygen for hypoxia. If we are able to treat it timely, we can actually reverse it also. Rehabilitation, memory training, cognitive rehab, structural routines. Psychosocial support, support for patient and caregivers, help with daily living. Avoid alcohol substance, essential in cases related to alcohol abuse. Prognosis depends upon cause and severity. Wernicke's may improve with early treatment, but Korsakoff is always permanent. Trauma-related amnesia may improve over time. Transient global amnesia usually resolves fully. Now, organic mood disorders. Organic mood disorders refer to the mood disturbances, which is depression or mania, that are directly caused by physical, organic medical condition or substance. These are not primary psychiatric disorders, but rather secondary to an identifiable brain or systemic condition. Neurological causes of organic mood disorders: traumatic brain injury, the most common one. Second most common one is stroke, especially the left frontal lobe for depression and right for mania. Very important for us to know which lobe gets affected, which side of frontal lobe gets affected for which symptoms. Parkinson's disease, Huntington's disease, multiple sclerosis, brain tumors, epilepsy, especially temporal lobe epilepsy. Patients with long-standing epilepsy history, long-standing temporal lobe epilepsy history are hell-bound on developing organic mood disorders in their future. Systemic metabolic causes like hypothyroidism, which is the most well studied amongst all the other in psychiatry, which is linked with depression, and hyperthyroidism, which may cause anxiety or mania. Cushing syndrome, Addison's disease, vitamin B12 deficiency, HIV/AIDS, and SLE. Substance or medication-induced corticosteroids can cause mania or psychosis. Interferon alpha may cause depression. Alcohol and drug abuse or withdrawal, and chemotherapy agents. Organic mood disorders and primary mood disorders. How are we supposed to differentiate between them? It is very important for both the specialities. Caused by medical and organic factors, absolutely. There's no identifiable physical cause. And with organic mood disorders, the onset is often atypical or late in life, whereas primary mostly begins in the adolescence and early adulthood. So resolved through the treatment of the cause may require a lifelong psychiatric treatment. This is another case snippet. So 58-year-old male presented with low mood, fatigue, irritability, and lack of interest from past 3 weeks. There is a history of recently discharged from hospital after a traumatic brain injury due to road traffic accident about 2 months ago. No prior history of psychiatric illness. Since the injury, he has become withdrawn, tearful, reports anhedonia, early morning awakening, poor appetite, and suicidal ideations, and no psychotic features. On examination, neurological examination, residual right-sided weakness and mild slurring of speech is present. MMSE score is 27/30. Affect is sad, congruent. Inside is partial. And investigations in CT brain suggestive of left frontotemporal contusion and encephalomalacia. Blood investigations are within normal limit. Diagnosis is organic depressive disorder. Why is it so? Though the duration of illness is 3 weeks, we can make it a depressive disorder. F32 can be made very easily, but look at the age of the patient. It is late onset. Look at the history of the patient. 2 months back, he had a traumatic brain injury. Look at another history, that there is no history of any previous psychiatric illness in the patient. So these factors, and then the CT investigations, they are also suggestive of a left frontotemporal confusion. So all of these workup can actually make us differentiate between organic mood disorders and primary mood disorders. Organic psychosis. Organic psychosis refers to psychotic symptoms like delusions, hallucinations, disorganized thinking or behavior that arise as a direct consequence of physical illness, brain disorder, or substance use. Unlike functional psychosis like schizophrenia, organic psychosis has a clear, identifiable medical cause. So what are the features? Psychotic features where delusion, hallucination, visual are more common than auditory, and disorganized speech. This is not a clue point basically that a lot of schizophrenia patients also have visual hallucinations. But still, if you come across a patient with visual hallucinations, you can always rule out organic cause. Identifiable cause, linked to medical, neurological, or toxic condition, abrupt or fluctuating onset. Symptoms often start suddenly or fluctuate in intensity. A very important point, because with primary psychosis, the symptoms will never, although they might occur suddenly, but they will never be fluctuating. Even with the ATPD, it's not fluctuating that much. Cognitive involvement may coexist with confusion or memory issues, but not always. Resolution may resolve if underlying cause is treated early. DSM-5 criteria says that there has to be prominent hallucinations or delusions, and symptoms have to have a direct physiological consequence of medical condition. Symptoms not better explained by a primary psychiatric disorder. And when we say primary psychiatric disorder is that the criteria for the other primary psychiatric disorders should be met. How are we supposed to approach these patients? So we have to treat the underlying cause. Example, antibiotics for infection, removal of the brain tumor, correct electrolyte imbalance. Psychotropics, antipsychotics in low doses for severe agitation. It is important for us to understand it is not for the treatment, but for severe agitation. It is basically symptomatic treatment. Avoid unnecessary medications, especially those that are going to worsen the cognition, like benzodiazepines and elderly. And supportive care, calm environment, reorientation, and family support. Important considerations: always rule out organic cause first before diagnosing primary psychotic disorder. Visual hallucinations are more common in organic psychosis than in schizophrenia. Fluctuating symptoms may indicate delirium with psychotic features rather than primary psychosis. Differentiate between organic psychosis and functional psychosis, wherein we have taken the example of schizophrenia. So identifiable medical and neurological causes there. Schizophrenia, mostly you have socio-biological causes. Often sudden onset and late in life, gradual onset, often in adolescence or early adult. Visual hallucinations are more common, whereas schizophrenia auditory hallucinations are more common, but it can occur the either way as well. Organic psychosis patient can also have auditory hallucinations. Schizophrenia patients can also have visual hallucinations. Symptoms fluctuate or worsen with illness. Symptoms are stable or progressive. Resolve with treatment of the cause. Long-term psychiatric treatment is usually needed. A 65-year-old man presents with sudden onset of visual hallucinations, delusions that his food is poisoned, and disorganized speech. Imaging shows a frontal lobe tumor. Symptoms improve after surgical removal and corticosteroid treatment. Diagnosis is organic psychosis due to brain tumor. Now, up until we had done imaging, if you look at the history above the imaging point, it can also be ATPD. If you look at it, it can also be dementia-induced psychosis. So therefore, it becomes very important and very crucial to rule out organic causes in all the patients who come to us with psychiatric illnesses and psychiatric symptomology as well. Because a lot of times they will present to us, the history will be very much painted like a psychiatric patient. But when we order for investigations, then is when we come to know, okay, it is basically because of some organic cause. Now, in the end, I would like to summarize by saying that prognosis depends upon the reversibility of the disorder. And another thing is that we have to work as a team, and it becomes important and very crucial. Psychiatry ka Ramband tool is history taking. So anything, whenever psychiatry is mentioned anywhere, any time in the world, remember detailed history taking is the tool, and it is the key. These are my references. Thank you.
Good afternoon, everyone. I am Dr. Neal. I am a psychiatry resident in SMC and CSSH Meerut. Today, we will be basically discussing about emergencies resulting from substance withdrawal and intoxication. So, majority of the substances will be looking in three forms. One will be your acute intoxication, overdose, and then withdrawal. So, introduction, substance use disorders will be going through alcohol, opiate, cocaine, hallucinogens, benzos, and summary. Hallucinogens also include your party drugs. Now, first of all, to understand withdrawal, we need to know what substance use disorder is. So, to establish substance use disorder, there is something called as the dependency criteria. If you have 3 out of these 6 features present in a patient, you say that the patient is dependent on a certain substance. So, what all do we ask on history? We ask for tolerance, which is increasing amount to achieve the same effect over time. We ask for withdrawal, physical or psychological symptoms when not using the substance. We ask for craving, that is an irresistible desire to use the substance. Loss of control, inability to control the amount, duration or intensity of use. Salience, substance has become the most important aspect of life. So, socio-occupational neglect aa jata hai. Patient stops interacting with his family. जो वर्क रिलेटेड चीजें होती है उसमें प्रॉब्लम्स आने लग जाती है एंड कंटिन्यूड यूज डिस्पाइट हार्म so persistent use despite awareness of negative consequences. So a lot of times you have alcoholics admitted for ALD, CLD, they have a lot of deranged LFTs, and despite knowing all of these things they still continue the use. So that is continued use despite harm. So any 3 out of these 6, we will say that the patient is dependent on a certain substance. Now, what is intoxication? The presentation is characterized by transient and clinically significant disturbance in consciousness, cognition, perception, affect, behavior, or coordination that develop during or shortly after the consumption or administration of substance. So basically, someone has taken a substance, and after that, there is some disturbance in the person's consciousness, disorient ho gaya, cognition mein अंडरस्टैंडिंग में दिक्कत होने लग गई, परसेप्शन, he might be seeing something as something else, or he might be seeing or hearing something that does not exist at all, affect behavior or coordination. The symptoms are compatible with the known pharmacological effect of the substance, and their intensity is closely related to the amount of the substance consumed. The symptoms of intoxications are time limited and abate as the substance is cleared from the body. So, depending on the substance clearance, वैसे वैसे intoxication के symptoms भी कम होते जाएंगे. So, this is intoxication. That means acutely the person has consumed a certain substance और उसके हमको symptoms which correlate to how the substance behaves वो हमको मिल रहे हैं. So that becomes your intoxication. Now what is withdrawal? The presentation is characterized by clinically significant cluster of symptoms, behaviors and or physiological features that occur upon cessation or reduction in the use of substance. So usually, as we have seen, substance use disorder का criteria dependence का, if a person usually a person who's fulfilling the dependence criteria, that person stops the substance or reduces the amount of substance taken, we see something called as withdrawal in that person. Note, substance withdrawal can occur when prescribing psychoactive medications, example opioids, anxiolytic stimulants, have been used in standard therapeutic doses. Oftentimes, जो SSRIs भी हम देखते हैं, when we give them at adequate doses and we suddenly stop them, you see something as SSRI withdrawal symptoms. Now, understand this one thing. You take a substance, right? After that, you are going to see intoxication. So, intoxication symptoms will be what the substance does to you. So if it is alcohol, for example, alcohol is a CNS depressant. So you take alcohol, intoxication में तुमको क्या symptoms मिलेंगे? CNS depression, right? Intoxication का next step क्या होगा? Overdose. So intoxication symptoms, but at a on steroids, or to be accurate, severe than intoxication. And what will be withdrawal? Withdrawal will be completely opposite of that. So in alcohol you have a basic depressant effect, उसका ही opposite जब वो substance नहीं मिल रहा है तो वो substance का effect चले गया है, so you'll get autonomic hyperactivity, tremors, restlessness, completely opposite of what the symptom is. So whenever you're looking at a substance, intoxication and overdose will be what the substance does, and withdrawal will be completely opposite to what the effect of the substance is. This is the basic understanding of what is intoxication, overdose and withdrawal. So knowing these three things is important when you're seeing a patient. So we'll now dive into alcohol withdrawal. Alcohol withdrawal obviously will be opposite to what we see. So it could be complicated or it could be uncomplicated, occurring in 6 to 48 hours, and complicated is what you see with seizures, delirium, tremens. So this is what signs you see with alcohol when it is in the blood. This is for acute intoxication. कि तुम्हारे पास पेशेंट आया है, अगर उसका ब्लड कॉन्सेंट्रेशन 20 to 30 mg per deciliter है, तो उसमें क्या होगा? स्लोड मोटर परफॉर्मेंस, डिक्रीज थिंकिंग एबिलिटी. द लीगल लिमिट इज 30 units, so it's around 30 mg per deciliter. So after that you get 80 to 200, wherein you have incoordination, judgment errors, mood lability. 200 to 300 is where slurring of speech and blackouts is there, and more than 300 is impaired vital signs and possibly death. Usually your emergent situation will be somewhere when your blood alcohol concentration reaches 200 plus, and 350 के ऊपर coma, death वो वाला range चले जाता है. So what are the features of alcohol withdrawal? As discussed, alcohol withdrawal के जो features हो गए, that will be opposite to what alcohol does to the body. So alcohol causes a basic depressant effect, so उसको हटाओगे तो you will have autonomic hyperactivity. तो tachycardia, hypertension, tremors, diaphoresis ये अल्कोहल में दिखेंगे. Increase hand tremors. अल्कोहल एक drowsiness cause करता है, तो अल्कोहल withdrawal में insomnia दिखेगा, nausea, vomiting दिखेगी, hallucinations, illusions दिखेंगे, psychomotor agitation दिखेगा, and anxiety and GTCS. A lot of times in your withdrawal you will also get GTCS, which will again study आगे in complicated withdrawal. So this is basically an overview of alcohol withdrawal में क्या क्या features दिखते हैं. This is your basic timeline कि how at what time what will develop, but this is not hard and fast. This is basically just a general estimation. So knowing this or not knowing this is not that important. Now we'll walk into what are the complications occurring. So classical alcohol withdrawal syndrome, AWS, alcohol withdrawal syndrome. What is it? It typically begins within 6 hours of the last alcohol intake, peak at 24 to 48 hours. What will the patient show to you? Your patient will come with GI complaints, tremors, sweating, anxiety, agitation, and headache. Usually at this point, the patient himself or herself is able to tell the symptoms. I have consumed alcohol XYZ hours ago, and he'll be kind of oriented to tell you कि मुझे ये हो रहा है, मुझे anxiety हो रही है, sweating हो रहा है, and खुद patient काफी history दे पाएगा. So if the patient is able to give a proper history, is oriented, he's probably in the alcohol withdrawal syndrome zone. After this can be alcohol withdrawal hallucinosis. This can occur independently of alcohol withdrawal syndrome. So the patient could be that he does not have any tremor, sweating, anxiety or headache, but उसको hallucination चालू हो गया है, and history पूछने पे you will find कि recent alcohol consumption है somewhere around 6 to 12 hours ago. So insight is usually preserved. The patient is able to tell कि I am seeing something. वो hallucination के लिए उसका कुछ insight present रहेगा. Usually when we see schizophrenics or psychotic disorder, उसमें the patient does not know that he is actually having a hallucination. But जब alcohol hallucinosis हो रहा होता है, तब patient is somewhat aware कि हाँ मैंने शराब छोड़ी है, इस वजह से मुझे शायद ऐसी चीजें कुछ दिख रही है. So somewhere insight is slightly preserved. Then comes alcohol withdrawal seizures. This becomes your complicated withdrawal. These are typically generalized tonic-clonic seizures, GTCS. अभी usually पूरा protocol status epilepticus का GTCS का सब में 4 mg lorazepam ही हो चुका है. So whenever you have alcohol seizures also, you will give 4 mg lorazepam IM stat. The risk is higher in individuals with previous episodes due to kindling effect. Kindling effect is कि धीरे धीरे उस because of having continuous seizures, the seizure threshold kind of decreases and उसका seizure propensity बढ़ जाता है. So पहले उसको काफी बारी seizures आए रहते हैं, तो उस वजह से उसके seizure आने के chances और बढ़ जाते हैं. Seizures usually occur 6 to 48 hours after the last alcohol intake. Multiple seizures can occur during a single withdrawal episode. So at this point, substitution therapy becomes very important. High dose benzodiazepines हम चालू कर देते हैं once we know that it is complicated withdrawal. Alcohol withdrawal delirium. Now delirium usually begins after 3 days of last alcohol intake. Possibly not something you would see in the emergency department because by this time the patient or the patient's family would have already brought you the patient. पहले ही तुम्हारे पास पहुंच चुका होगा before going into delirium. But it could happen कि दोस्तों के साथ पीता वीता है, 2-3 दिन गुजर गए हैं, symptoms आ रहे हैं, but the friends were like इसको हर बार ही होता है, or the family was like हर बार ही होता है, so they did not bring the patient to the emergency department, and the patient comes to you directly in delirium. Disoriented होगा, he would not know where he is, what he is doing. Oftentimes visual hallucinations हो गए. Very classical is that they will visualize a thread floating in the air. They'll try to grab the thread. They'll try to wrap the thread. So visual hallucinations हो गए. Occupational हो सकता है कि you know if the patient is like a taxi driver, तो वो triage में बैठा होगा and he'll be like चलो भाड़ा भरो, गाड़ी में बैठो, मुझे यहाँ छोड़ के आना है, तुमको वहां जाना है. So occupational delirium wherein the patient believes that he is currently working in whatever occupation he is doing. So ये सब symptoms तुमको emergency department में दिख सकते हैं. It can last from a few hours to 2 to 3 days, but in rare case may extend up to 50 days. The severe form is known as delirium tremens, DT, which includes tremors and autonomic dysfunction. Now, in untreated cases of delirium tremens, mortality is up to 20%. Usually they say कि 5 to 10% of all DT cases में death हो जाती है. But in the past 2.5 years, हर महीने में 2 से 3 cases we have of DT. If you properly manage them, I haven't seen a single death occurring due to DT. So despite having a very high death rate, if you properly substitute with benzos, तो तुम आराम से वो चीज को मैनेज कर सकते हो. Recently only Friday, Saturday, Sunday, and Monday. Now 3 days we are managing a patient in DT, and is fairly stable, and we know that in the next 3-4 days he'll come out of it also. So what do you usually see in DT? Clouding of consciousness, hallucinations and illusions. I think even he is having occupational hallucination हो रहा है उसको. He's standing on the gate saying कि मुझे दिल्ली की बस पकड़नी है, मुझे यहाँ जाना है, वहाँ जाना है. So even he is disoriented, he can only recognize his father and a few people, but he is completely disoriented to time and place. Marked tremors. Even if the patient is normally standing, you'll see tremors in the hands, and autonomic hyperactivity, electrolyte imbalance. Delusions may be present and may lead to coma and death. Always remember, electrolytes karwana, serum electrolytes becomes one of the most important things, is because in a lot of the substances you will find electrolyte imbalances, and these two precipitate delirious states. So you have to know, is it your substance causing delirium or is it an electrolyte imbalance causing delirium? So always inquire for an electrolyte imbalance or serum electrolytes. If it is not done, then get it done. It may lead to coma and death. Then there is Wernicke's encephalopathy, the classical triad of Goa, which is basically global confusion, ophthalmoplegia and ataxia. This is due to thiamine deficiency, which is often missed. Now what management becomes? You have to give high dose benzodiazepines. So usually you will have to convert it depending on how much alcohol he is taking. But if the patient arrives to you, you have to ask what was the last consumption. 6 to 8 hours agar usko ho gaye hai, and you are getting a history of alcohol consumption 6 to 8 hours ago, and you are getting the features of alcohol withdrawal, then you need to immediately administer around 4 mg of lorazepam. But you have to be sure कि 6 to 8 hours usko last consumption को हो चुके हैं. After that, vitals monitor करना है. You have to maintain the vitals. Then whatever is deranged, you will individually manage it depending on whatever is gone. Thiamine, fluid and electrolytes. Beta blockers can be given if the patient is tachycardic, and serum electrolytes should be done. So this becomes basically our alcohol. In alcohol, majority of the things that will be seen in the emergency department is withdrawal. But in opioid or like opioid, cocaine, hallucinogens, benzodiazepines, you will see overdoses in your emergency department. So in opioid, it becomes important to know how overdoses look or intoxication look rather than withdrawal. But we'll still get a basic idea of how withdrawal is also there. Now opioid again is similar to alcohol in the form that it is somewhat a depressant. So similar logic हम opioid पे भी लगाएंगे. Time course for the development of opioid dependence is variable, generally from days to weeks, contingent on factors such as specific opioid formulation and routes and frequency of administration. Short-acting opioids होते हैं such as heroin and oxycodone. Several times for at least 2 weeks is needed before opioid dependency develops. Furthermore, the degree of dependence and the severity of opioid withdrawal is directly related to intensity of exposure. In short, how much opioid for how long will determine how much withdrawal is seen. In opioid withdrawal, you will basically see anxiety, irritability, muscle ache, bone pain. This is a little classical for opioids, that you'll have a lot of muscular and bone aches. Nausea, vomiting, lacrimation, rhinorrhea, diarrhea. This is also somewhat classical for opioid withdrawal. Insomnia, dilated pupils, sweating, piloerection, and yawning and running nose. So this is basically a classical presentation of how opioid withdrawal will be looking like. What do you do when you get a case of opioid withdrawal? You administer COWS and you see if it is mild, moderate or severe. This is a COWS PDF. Anytime you type COWS opioid, you will get a PDF online. It's a free resource. Now we'll move on to intoxication, something that is more commonly seen in the emergency setting. Intoxication hai, so it will be similar to what the features of the drug is. So there will be euphoria followed by apathy or sedation. What are the physical signs? Pupillary constriction, impairment in attention or memory, drowsiness or coma, slurred speech. impaired judgment, psychomotor agitation or retardation, and dysphoria. Now, what is opioid overdose? Again, acute intoxication at a higher level. This is a life-threatening emergency with severe respiratory depression. So in opioid overdose, you'll see what classically is there is a respiratory with a high level of respiratory depression. The patient that will come to you will be unconscious and unresponsive, pinpoint pupils. Now, may dilate in severe cases due to hypoxia, but you will see pinpoint pupils in opioid overdose. Slow, shallow or absent breathing, cyanosis and pulmonary edema in severe cases. So what will be your things which will direct you? Your pupils, pinpoint rahenge, unconscious, unresponsive patient rahega. The family will give you a history of opioid consumption, shallow, slow or absent breathing and cyanosis present. So this is basically a chart comparing your opioid withdrawal, intoxication and overdose. Something to look for is your muscle tone. In withdrawal, you have tremors, cramps. In intoxication, your muscle tone will be flaccid, and in opioid overdose, flaccid or no reflexes. Then again, rhinorrhea, lacrimation, and yawning will be present in withdrawal. Dry mouth, no tears, and dry or cyanotic mucosa. So to summarize, what we need to remember for opioid is in withdrawal, it is a sympathetic storm. So you'll have dilated pupils, sweating, pain, and GI upset. Pain, classically muscle and bone pain. In intoxication, you will have sedation, small pupils, and slow breathing. Then overdose, which becomes a medical emergency, in which you will see a patient unresponsive or unconscious. Apnea will be present, pinpoint pupils, and here we will give naloxone plus airway management. Airway securing the airway basically. So we'll see the withdrawal management. Treatment of opioid withdrawal, although very uncomfortable, opioid withdrawal is rarely life-threatening. So majority of the times, opioid withdrawal though might present in the emergency department, but it's not a life-threatening condition. However, untreated opioid withdrawal commonly result in return to high consequences of opioid use with a high risk of overdose death after discharge from the emergency department. In opioid withdrawal, we will basically be managing the symptoms that will be seen with opioid withdrawal. Clonidine you can give for your autonomic hyperactivity, loperamide for your diarrhea, and ondansetron for your vomiting. This is basically what you will be doing as a symptomatic management. Again, now if you see that there is moderate to severe opioid withdrawal, that you have COWS score somewhere around 8 to 13 ke upar, depends, like some clinicians consider more than 8, some clinicians consider 13. So if you have admitted the patient or तुम्हारे पास COWS score आ गया है, it is somewhere more than 13, so you can go for clonidine. You have to make sure that blood pressure is more than 90/50 and heart rate should be more than 50 beats per minute. So you give clonidine 75. After that, you again measure the blood pressure after 30 minutes, and if you see that the blood pressure is maintained, you can again give clonidine. Again, there is something called as opioid agonist treatment, wherein you hear a lot about buprenorphine substitution. This also can be done, but this is basically done after a little while of admission. Buprenorphine should be used with caution in patients with respiratory deficiency, urethral obstruction, and diabetes. It also reduces craving. So once you have managed the patient, symptomatic management ho gaya hai, the patient is pretty much out of harm's way, you can then also start buprenorphine. Now, opioid overdose management. This is something that will be classically seen in the emergency department. So withdrawal is not something which becomes a very emergent situation, but opioid overdose becomes an emergent situation. We have seen the classical signs of opioid withdrawal, opioid overdose, pinpoint pupil, unresponsive patient or unconscious patient, very shallow breathing. So if you have a history of opioid consumption, so if you have such a patient, you will administer naloxone. Now, before administering naloxone, the patient should receive 100% fraction of inspired oxygen assisted by back wall ventilation until they become more alert and cooperative, or until naloxone is administered. So just before administering naloxone, 100% fractional inspired oxygen dena hai, and then you will give naloxone. How much naloxone? 0.4 to 1 mg of naloxone can be given. The starting dose for children is 0.1 mg per kg, but majority of the patients that you will see will be adults. So anywhere from 0.4 to 1 mg. Preferably, what in practice it is done is 1 mg is given, and you can give this up to 10 mg every 1 to 3 minutes. May you can repeat, but usually take a time of 2 minutes. So you give around 0.5 to 1 mg, wait for 2 minutes. If the symptoms are not relieved, give 0.5 to 1 mg. So वो करना है. The goal is not to wake up the patient, but just to reverse the respiratory depression. So once the patient is out of respiratory depression, you can stop the naloxone. Repeat doses of 2 mg may be required every 3 to 4 minutes for a total of 10 mg. So 10 mg is your ceiling naloxone. Usually you would not require to reach 10 mg, but that's your ceiling, and for clinical knowledge we should know where to stop. Next we move on to cocaine. Patients suspected of cocaine toxicity may have the following features. Again, as we have seen with opioid overdose becomes an emergent situation. In the same way, cocaine overdose becomes an emergent situation. Majority of the patient who will present will be of OD, overdose cases हो गए तुम्हारे पास. क्या दिखेगा? Hypertension, altered mental status, seizures, chest pain, dyspnea, epistaxis. Now, opioid and alcohol are usually depressant substances. Cocaine is a stimulant. So in overdose, what will you see? Stimulant का excess. So क्या होगा? Stimulant में hypertension दिखेगा. फिर seizures, chest pain, dyspnea, epistaxis, headache, paranoia, neurological deficits, hyperthermia होगा, vascular spasms होगा, distal pulses feel नहीं होगी, diaphoresis होगा, severe agitation होगा, restlessness, confusion, blurred vision, corneal ulceration, vision loss, diarrhea, vomiting, abdominal pain, and excited delirium. So पूरा का पूरा excitation वाला phase में patient आएगा तुम्हारे पास. What are the stages of acute cocaine toxicity? So 3 stages में we can divide cocaine toxicity. Stage 1 is your headache, nausea, vertigo, twitching, pseudo hallucinations and preconvulsive movements. पूरे seizures नहीं आ रहे, but somewhat it feels that the patient might have a GTCS happening. Increased BP होगा, ectopic beats feel होगी, tachypnea होगा, hyperthermia होगा and paranoia होगा. Euphoria, confusion, aggression, agitation, emotional lability and restlessness. Cocaine में a lot of times agitation and this aggressiveness बढ़ जाता है. So this is your stage 1 of acute cocaine toxicity. Cocaine toxicity you can also call as cocaine overdose, but we call it acute cocaine toxicity. Stage 2 will be a step ahead. In CNS you'll see encephalopathy. We had seen that it looked like the patient might be having seizures. In stage 2 you'll have seizures, increased deep tendon reflexes, incontinence, hypertension, arrhythmias, peripheral cyanosis, tachypnea, gasping, apnea, irregular breathing and hyperthermia. This is stage 2. In the final stage 3 you'll have oriflexia. बहुत हाइपर रिफ्लेक्सिव हो गया, डीप टेंडन रिफ्लेक्सेस बहुत ज्यादा बढ़ गए, उसके बाद में एकदम ऑरिफ्लेक्सिया आ गया. फिक्स्ड एंड डायलेटेड प्यूपिल्स. ओपियोइड में पिन पॉइंट प्यूपिल्स है, कोकेन में डायलेटेड प्यूपिल्स है. लॉस ऑफ वाइटल फंक्शन, हाइपोटेंशन, वेंट्रिकुलर फिब्रिलेशन एंड कार्डियक अरेस्ट, एपनिया, रेस्पिरेटरी फेलियर, साइनोसिस एंड अगोनल ब्रीदिंग. Agonal breathing is very classical in acute cocaine toxicity, in which there is a sudden gasp that the patient takes, wherein you feel that the patient is not breathing at all, and then suddenly एकदम से वो gasp करता है air के लिए, and then for a while he does not breathe. So that pattern of breathing is, in layman terms, can be called as agonal breathing. Here we have compared cocaine withdrawal with cocaine toxicity. Now, as we can see, we have not discussed withdrawal separately, so we'll see here only. Withdrawal में क्या होता है? कोकेन स्टिमुलेंट है, उसके अपोजिट इफेक्ट आएगा तो फटीग, डिप्रेशन, स्लीपीनेस, इंक्रीज एपेटाइट, विविड ड्रीम्स एंड क्रेविंग होगा, लो मूड होगा, हाइपोटेंशन होगा, इट्स रेयरली लाइफ थ्रेटनिंग, सपोर्टिव केयर इज बेसिक मैनेजमेंट, न्यूट्रिशन, देन role of antipsychotics, you rarely need antipsychotics, and high craving and relapse risk is there, and cocaine overdose or toxicity is completely opposite of what we have seen right now. Now, management of cocaine intoxication. For agitation and anxiety, what will you give? Benzodiazepines, diazepam 5 to 10 mg IV/IM repeated as needed. Diazepam ka lorazepam mein conversion is 1:10. So if you are giving 10 mg of diazepam, you'll need 1 mg of lorazepam. I am giving this conversion is because a lot of places they don't use diazepam, they use lorazepam. So just knowing what the basic conversion is. So diazepam 5 to 10 mg IV/IM repeated as needed. Monitor for respiratory status closely. So our basic aim becomes CVS and रेस्पिरेटरी सिस्टम. सो जो रेस्पिरेटरी डिप्रेशन हुआ है बहुत ज्यादा, उसको हमको मैनेज करना है. So we'll monitor the respiratory status closely. For severe agitation or psychosis, we can use a low dose antipsychotic. Haloperidol 2 to 5 mg IM दे सकते हैं. So that becomes one. For seizures and extrapyramidal symptoms, we have to look out for. If the patient is having a GTCS or a seizure, then we will again give lorazepam. Treat specific medical complications. So for cocaine intoxication, your basic aim becomes कि what symptoms you are seeing, उसको individually तुमको manage करना है. Hypertensive crisis हो सकती है, cardiac arrhythmia में ACLS protocol follow होगा, seizures में benzodiazepines होगी, which is basically the norm now become as lorazepam, and after stabilization, comprehensive assessment for withdrawal and further management. Obviously, now the patient is in intoxication or overdose. With time, the patient will also can develop withdrawal. So once you admit the patient, you will also look out for withdrawal signs. So in the emergency department, what becomes the goal of treatment? What symptoms you are seeing? वो symptoms को individually manage करना है, specifically your respiratory symptoms. Now hallucinogens are substances that will now move on to hallucinogen. What are these? These are substances that can alter perception, thought and feeling, creating a temporary state of altered awareness. LSD, psilocybin, PCP, ketamine, MDMA, DMT, all of these so-called party drugs वाला category becomes your hallucinogens. Effects क्या क्या होते हैं? Very well known visual auditory hallucination, paranoia, anxiety, panic attack, depersonalization or derealization. A lot of times when you take substances, the patient says कि ऐसा लगता है कि I am completely different and the world is completely different, or the patient says that I don't exist at all, I am existing in some other realm and this world is functioning in some other realm. तो वो depersonalization, derealization वाला हो जाता है. PT होती है bad trip, wherein intense fear, confusion and psychosis like state. Emergency department में patient आया है, high chances the patient is in BT, मतलब bad trip में आया है. Nobody is going to come for a euphoric experience, wherein depersonalization or derealization हो रहा है. So it is possibly the main effect for which the substance was taken. So if the patient is landed to your emergency department, it is because the patient's friends and all are now worried कि हमने ये कोई substances को खिला दिया था and इसने पहली बार ये नशा किया है या फिर ये नशा करते रहता है and इसको ये सब symptoms दिख रहे हैं और हमको नहीं पता क्या करना है. So intense fear, confusion and psychosis like state will be usually seen in the patient that is brought to the emergency department. Physical signs क्या होगी? Tachycardia, dilated pupils, sweating, tremors, nausea, vomiting. And the best part is that majority of the times you get a very good history of these party drugs. The friends and all, though initially might be hesitant, but very clearly tell you what the substance and everything is. So here taking the history or understanding what the substance is becomes a little easier. Now severe toxicity, usually seen with PCP or synthetic hallucinogens. Violent agitation, self-harm. The patient has consumed a party drug and now he has started beating up everybody around him. Or seizures. You gave the party drug, the patient started having seizures. Coma, renal failure and hyperthermia. So usually for violent agitation, self-harm, seizures and coma is what the patient is brought to the emergency department for. Again, the management becomes supportive care, calm environment and reassurance. Usually try to keep the patient in a very dim lit or a dark kind of an environment. उसको एक calm environment में, usually not an ICU with 10 things beeping around him, usually an isolated room, उसमें रखना है. Try to dim the lights, keep it, do not make it bright. Benzodiazepines are the first line for severe agitation, anxiety and seizures. Depending if the patient has agitation and all, then you'll use your short acting clozapam, metazolam, all of these things. Then अगर seizures आ रहे हैं तो again lorazepam, diazepam पे तुम जा सकते हो. Antipsychotics only if benzodiazepines fail or psychosis is severe. Usually we do not require antipsychotics in such cases. Cooling measures for hyperthermia and avoid restraints can worsen agitation and increase risk of rhabdomyolysis. Coming to benzodiazepines withdrawal. Now in benzos, we see both withdrawal and overdose. So first we'll discuss withdrawal. The following are common features of benzodiazepine withdrawal. Anxiety, insomnia, craving. What does benzo do? Benzo relieves your anxiety, is a sedative and a hypnotic. So it will relieve your anxiety and it's a hypnotic, so it will make you sleep. So withdrawal में complete opposite मिलेगा, anxiety, insomnia and cravings, muscle aches and headaches, numbness, tingling, hypersensitivity to noise, light and touch, dizziness, impaired concentration and memory, and depersonalization and derealization. Classically seen with benzodiazepine. Withdrawal seizures are more likely to occur after abrupt cessation of long-term use of high doses, in particular short-acting drugs such as alprazolam. Now, we are obviously giving a lot of benzos for your seizures. So if the patient is habitual to taking a lot of benzodiazepines, तो तुमने sudden withdrawal कर लिया तो उसको seizure precipitate होगी, because opposite reaction is a basic logic for withdrawal. So benzodiazepine withdrawal में seizures and alcohol withdrawal में seizures are very classical. The safest way to manage benzodiazepine withdrawal is to give benzodiazepines in gradual decreasing amounts. Whatever benzodiazepine the patient was taken, convert it and select your choice of benzodiazepine and give the appropriate doses. So वही है, जो benzodiazepine ले रहा है उसको convert करके appropriate doses में करके धीरे-धीरे tapering off करनी है. This helps to relieve benzodiazepine withdrawal symptoms and prevents the development of seizure. First step in benzodiazepine withdrawal management is to stabilize the patient on an appropriate dose of diazepam. Again, diazepam, lorazepam, whatever you want. Majority of the text over here, because are from American references, so diazepam बहुत ज़्यादा use होता है. UK, India में lorazepam ज़्यादा use होता है. Calculate how much diazepam is equivalent to the dose of benzodiazepine that the patient currently uses to a maximum of 40 mg of diazepam. Benzodiazepine overdose. Now, classical presentation in patients with isolated benzodiazepine overdose will include CNS depression with normal or near normal vital signs. This is a very important line. Majority of the times whenever you are giving CNS depressants, it will come with other effects on your basic vital signs. कोई hypotension हो सकता है या hypertension हो सकता है. तो जो benzodiazepine होगा वो CNS depression तो cause करेगा, but when you'll be checking for the other vital signs, temperature normal होगा, BP normal होगा, pulse normal होगा, so these other vital signs will be normal, but still there will be central nervous system depression. Many patients will still be arousal and even provide a reliable history. Classical symptoms include slurred speech, ataxia and altered mental status. Respiratory compromise is uncommon in isolated benzodiazepine ingestion. So SpO2 भी देखोगे तो वो भी normal की तरफ ही होगा. Usually a lot of time benzos के साथ patient might also be taking other substances. So if it is isolated benzodiazepine तो तुमको बस CNS depression ही मिलेगा. Patients with severe toxicity will present in a stuporous or comatose state and immediate airway management and mechanical ventilation may be required. Now, what is the management? Mainstay treatment for acute benzodiazepine toxicity is supportive care, which may include endotracheal intubation to provide definitive airway management. Single dose or multi-dose activated charcoal, hemodialysis or bowel irrigation play no role in managing benzodiazepine toxicity. While the mainstay treatment of acute benzodiazepine toxicity or overdose is supportive care, there is, however, an antidote that may be used in limited situations. Usually not used, but flumazenil is said to be an antidote. But the thing is that the risk of using flumazenil outweighs the benefits. So, though it is called as an antidote, it is not usually used. Flumazenil is a non-specific competitive antagonist at the benzodiazepine receptor that can reverse benzodiazepine-induced sedation. However, in most cases, the risk of flumazenil usually outweighs the benefits in acute toxicity, and thus flumazenil is not recommended for routine reversal of this sedative agent. In short, we have to remember that for alcohol, we pay attention to withdrawal. For opioid overdose, for cocaine overdose, and for benzodiazepine, withdrawal and overdose both. These are the basic things that will be presented to you in your emergency department. Depending on what the patient has presented with, you will manage it accordingly. Thank you.
Good afternoon, everyone. I'll be talking on the topic fatal side effects of psychotropic drugs and its management. Myself, Dr. Shyamashish Gupta. The things which we are going to cover are the risk factors behind causing those side effects, the main four categories of the drugs and its side effects and its core management along with it. Firstly, we'll talk about the risk factors for the fatal side effects. First are the patient-related factors, the elderly or very young age, any comorbidities of liver or kidney dysfunction, genetic variations, presence or not, history of cardiovascular disease or mental illness or not, or any kind of previous drug hypersensitivity noted or not. Drug-related factors, high dosages or rapid dose escalation, long-acting formulations, example depot antipsychotics, polypharmacy and drug interactions, and use of high-risk agents like tricyclic antidepressants, lithium, and clozapine. So first we'll be talking about the antipsychotics. They are subdivided by the propensity for this adverse effects. The effect of the antipsychotics measures according to the receptors on which they are acting. While dopaminergic D2 antagonism in the mesolimbic area produces the antipsychotic effect, in the nigrostriatal pathway receptors, they produce the extrapyramidal side effects, and the receptors in the tuberoinfundibular pathway of the anterior pituitary produces the hyperprolactinemia. Antagonism at the muscarinic M1 receptors produce side effects like blurred vision, constipation, urinary retention, sedation, memory impairment, and sinus tachycardia. Whereas the antagonism at H1 receptor produces sedation and weight gain. The antagonism at alpha-1 adrenergic receptors produces dizziness, postural hypotension, bradycardia, and sedation. The risk of hypothermia with antagonism at serotonin 5H2 receptors. There's also side effect of prolonged QT interval because of the inhibiting cardiac potential ion channels. So first we'll be talking about the antipsychotic fatal side effect. Firstly is the neuroleptic malignant syndrome. The core clinical presentation which can be seen is the generalized lead pipe muscle rigidity. An elevated temperature would mostly be above 103 degree. Altered consciousness and autonomic system dysregulation. Autonomic instability, which would present in form of diaphoresis, tachycardia, labile blood pressure, urinary incontinence, pallor, and cyanoria. Other symptoms, dysphagia, trismus, dysarthria, myoclonus, akinesia, tremor, and delirium. Lab findings which are suggestive of it will be leukocytosis, metabolic acidosis, evidence of muscle injury with creatine kinase elevation. It's very important to rule out the organic cause behind it, to rule out for thyrotoxicosis, malignant hyperthermia, Parkinsonism, hyperthermia, and serotonin syndrome. For in patients who are already on medications, it's very important to rule out with serotonin syndrome. The basic difference would be the temperature would be elevated in both the cases, but it won't be above 103. And muscle rigidity won't be present in patients of serotonin syndrome. These are the presentation findings which were earlier also mentioned. The management, supportive interventions. The first line of medication treatment is the supportive intervention, IV hydration, temperature control, and in more severe cases, ventilator support or dialysis is also needed. Oxygenation, cooling blankets, ice packs, ice water enema, and antibiotics have a role. A rapid onset or worsening of symptoms requires transfer to a medical intensive care unit. Re-exposure to antipsychotic should be considered only after full resolution of the episode. These are the medications which can be used: amantadine, bromocriptine in 200 and 400 mg per day in divided doses, bromocriptine 2.5 mg twice a day or 3 times a day by mouth, and can be increased up to 45 mg per day. Levodopa, carbidopa, role, and dantrolene 1 mg per kg per day, preferentially for first 8 days, and then to be tapered and stopped. Also, other modalities which help is the role of use of benzodiazepines 1 to 2 mg intramuscular as a test dose. If it is effective, we can switch to the oral dose. And mostly considered when the catatonic symptoms are present of decrease in traction and prolonged posturing in a position. ECT have also role, but mostly ECT's role come when at least 3 ECTs are given. Other medication-induced movement disorder which is associated in use of antipsychotics is acute dystonia, which can present in abnormal positioning of the head and neck, like in torticollis and retrocollis, spasm of the jaw muscles, trismus, impaired swallowing. Speaking or breathing difficulty, thickened or slurred speech, deviated eyes in any direction, oculogyric crisis, and abnormal positioning of the limbs and trunks, opisthotonus. It can also present with severe reactions or laryngeal dystonia, which can compromise the breathing. And at that time, immediate recognition and treatment is essential. Parenteral intramuscular IM or IV benztropine can be used 1 to 2 mg or diphenhydramine roll, which produce rapid relief. Prophylactic use of anticholinergic medication as well as the ready availability of parenteral form is strongly encouraged. These are the other threatening side effects of the antipsychotics. Firstly is QT prolongation. Antipsychotics block cardiac potassium channels, which are linked to the prolongation of cardiac QT interval, which is a risk factor for Torsades d pointis. It is generally a dose-related risk factor, usually plasma level dependent. These are the normal values which should be checked for both men and female, and other ECG changes which should be kept in check for are atrial fibrillation, giant T-wave changes, and heart blocks. Mostly these are present at higher doses of the antipsychotics or in old age people. These are the effects of antipsychotics on QTC. The high effect drugs are the ones which have the most propensity for causing these side effects. Any IV antipsychotics, pymoside, sertinodol, these drugs individually or in combinations can produce these effects. The moderate effect drugs which have the chances but are less than the previously mentioned are amisulpride, haloperidol, chlorpromazine, quetiapine, and ziprasidol. The low chances of effects of the drugs are acinapine, clozapine, flupentixol, olanzapine, risperidone, and amisulpride. The other is the diabetic ketoacidosis. The mechanism involved in the development is mostly unclear, but is associated with 5-HT2A, 5-HT2C antagonism, which reduces plasma lipid levels, increases the plasma lipid levels, cause weight gain and leptin resistance. Insulin resistance can occur with the absence of weight gain as well. So these are the drugs which have high risk for causing the diabetic ketoacidosis: clozapine and olanzapine. with moderate risk with quetiapine, risperidone, and phenothiazines, and low risk with first generation antipsychotic like haloperidol. Minimum risk with aripiprazole, amisulpride, acinapine, and ziprasidone. The decay usually develops slowly, but when vomiting occurs, it's a life-threatening condition. It can present as form as thirst, frequent urination, high blood glucose levels, high levels of ketones in the urine. The other symptoms which can appear are constantly feeling tired, flushed skin, nausea, vomiting, abdominal pain, and difficulty in breathing, fruity odor on breath, and confusion and difficulty in paying attention. So managing decay is in an intensive care unit for the first 24 to 48 hours is highly advisable. The following points should be kept in regard when giving the management: correction of the fluid loss with IV fluids, correction of hyperglycemia with insulin, correction of electrolyte disturbances, particularly potassium loss, and correction of acid-base balance and concurrent infection if present. And it's very important at that time to stop the antipsychotic and only to start the antipsychotic once the episode is completely resolved. And the same antipsychotic should be mostly avoided. Drug-induced SIADH. The prevalence of SIADH has been estimated to be as high as 11% in acutely ill psychiatric patients. Hyponatremia is the most common finding, with confusion, nausea, headache, and lethargy. As the plasma sodium level falls, these symptoms become increasingly severe, and seizures and coma can develop. These are the drugs which are more common associated with drug-induced SIADH, with phenothiazines, haloperidol, risperidone, quetiapine, olanzapine, aripiprazole, and clozapine. Second, severe hyperlipidemia and hyperglycemia lead to secondary increase in the blood volume and cause pseudo-hyponatremia, more common with antipsychotic drugs used than in general population. Management: if mild fluid restriction with careful monitoring of serum sodium, refer to a specialist medical care if sodium is less than 125 millimole per liter. Switching to different antipsychotic, uh, demiclocycline can be considered. Lithium may be effective but is a potential toxic drug. Hyponatremia itself can predispose to lithium toxicity, so has to be given under only when needed. Pneumonia. The mechanism behind the antipsychotic causing it is not clear. The possibilities include sedation, which high risk with the drugs that show greatest H1 antagonism, dystonia, dyskinesia, dry mouth causing poor bolus transport and increasing the risk of aspiration. General poor physical health, perhaps some ill-defined effect on the immune response is also noted. With clozapine, pneumonia may be secondary to the constipation associated. In the recent studies, it is shown that the bipolar affective disorders have found clozapine, olanzapine, and haloperidol with increased risk of pneumonia, whereas lithium was the protective factor in such patients. As per the drug clozapine is considered, it has a serious rheumatological and cardiovascular side effects. Most important is agranulocytosis, which is most commonly noted. The targeted cells are the myeloid precursors and mature neutrophil. The absolute neutrophil count is the most common marker to be checked for, which decreases, and it's mostly not a dose-dependent side effect. It can occur within 2 to 3 months of starting the medication. The second is thromboembolism. The risk is estimated to be 1 in 1,000 to 1 in 6,000 patients treated. It is related to clozapine observed effects on the antiphospholipid antibodies and platelet aggregation. Mostly likely to occur in the first 3 months of treatment, but can occur at any time. The risk of fatal pulmonary embolism is estimated to be around 1 in 4,500 patients treated. Myocarditis and cardiomyopathy. It is also seen to occur within 6 to 8 weeks of starting clozapine, and cardiomyopathy may occur later in treatment, but can present at any time. Patients should be closely monitored for signs of myocarditis, especially in the first few months of treatment, with symptoms include checking for hypotension, tachycardia, flu-like symptoms, fever, fatigue, and dyspnea, with increased respiratory rate and chest pain. Signs include ECG changes, ST depression, enlarged heart on radiography, echo, and eosinophilia is also noted. Rapid dose increases, concurrent use of sodium valproate, and older age are the risk factors. It should be suspected in any patient showing signs of heart failure, which provoke immediate sedation of clozapine, and the referral is needed immediately. Presentation of cardiomyopathy varies somewhat, so that any reported symptoms of palpitation, chest pain, syncope, sweating, decreased exercise capacity, or breathing difficulty should be closely investigated. Risk of fatal myocarditis or cardiomyopathy may be as high as 1 in 1,000 patients. Younger patients have an increased risk of sudden death. So these are the now coming to the second class, which would be the mood stabilizer. These three drugs are which we are going to be talking about. Firstly, lithium. As a fatal side effect, we should be keeping in check about the lithium toxicity. Patients who are on longer treatment courses and also who are taking medication unsupervised without any consultation on base of a previous follow-up should be evaluated for mild to moderate intoxication. Serum lithium levels should be done, which would range between 1.5 to 2 milliequivalents per liter, with GI symptoms most common of vomiting, dryness of mouth, and abdominal pain. Neurological presentation with ataxia, dizziness, and slurred speech. Nystagmus, lethargy, and muscle weakness is also noted. Moderate to severe intoxication with lithium levels from 2 to 2.5 milliequivalent per liter. Anorexia, persistent nausea, vomiting would be present, and blurred vision, muscle fasciculation, clonic limb movement, hyperactive, DTR, delirium, convulsion, syncope, stupor, and coma. These are the other findings which can be present. Severe intoxication, which would present with serum levels of lithium more than 2.5 milliequivalent per liter, with generalized convulsions, oliguria, renal failure, and death. Management: shift the patient to the emergency, discontinue lithium, and do complete physical examination with mental state examination. Lithium level, serum electrolyte, RFT, and ECG should be done as soon as possible. If acute ingestion is suspected, do gastric lavage and absorption with activated charcoal. Vigorous hydration and maintenance of electrolyte is essential. Any patient with lithium greater than 4 milliequivalent per liter, hemodialysis should be initiated and should be repeated until unless the signs and symptoms completely disappear. Now coming on to the second drug of mood stabilizer, sodium valproate. Firstly, we'll talk about the hepatic failure. It is associated with use of sodium valproate, mostly seen in the first 6 months of treatment. Symptoms of liver problems: general feeling of discomfort, sluggishness, unusual tiredness or weakness, swelling of the face, loss of appetite, vomiting, stomach pain, dark urine can present. In patients who have seizure, loss of seizure control may occur as well. And pancreatitis as well. Symptoms of acute pancreatitis, which will also be precipitated and can present itself as well, with abdominal pain radiating to back, swollen and tender abdomen, nausea, vomiting, fever, and increased heart rate. The other fatal side effect of sodium valproate can be hyperamonic encephalopathy in patients who are also having UVA cycle disorders. Valproate induced hyperamonic encephalopathy is an unusual complication, which presents with decreasing level of consciousness, focal neurological deficits, cognitive slowing, vomiting, drowsiness, and lethargy. So it is very important before starting sodium valproate to get a baseline LFT levels check, and close clinical observation is needed. A rare side effect of it is as well granulocytosis. Now the third drug of mood stabilizer, carbamazepine. 3% of the patients treated with this drug presents with a generalized erythematous rash, which generally subsides on its own after a few days in 1 to 2 weeks. Serious exfoliative dermatological reactions can occur. Stevens-Johnson syndrome. Stevens-Johnson syndrome is a form of toxic epidermal necrolysis, which can cause the cell death, causing the epidermis to separate from dermis. It affects the skin and the mucous membranes. Begins with benign fever, sore throat, and fatigue, which is commonly misdiagnosed and is treated with antibiotics. Ulcers and other lesions begin to appear in the mucous membrane, almost always in the mouth and lips, but at times also noted in genital and anal regions. Those in the mouth are usually extremely painful and reduce the patient's ability to eat or talk and drink. It is a dermatological emergency. Now coming to the third class of drug, antidepressant and its side effects, threatening fatal side effects. Firstly, we'll be talking about the tricyclic antidepressants, which have established arrhythmogenic activity as a result of blockade of cardiac sodium channels and variability at the activity of potassium channels. It includes changes in PRM, QRS interval, and QT prolongation as well, with Brugada syndrome noted. Antidepressants are associated with arrhythmia and sudden cardiac death if given in high doses. It's a marker fatal toxicity index is a measure of overdose deaths per million prescriptions issued. The high toxicity as per this marker is noted for tricyclic antidepressant, so it should be avoided in any patient who is a known case or has a history of cardiovascular illness in the past. Medium toxicity for venlafaxine and low toxicity for SSRIs, an atypical antidepressant like mirtazapine. The other important and the common side effect noted is the antidepressant induced hyponatremia. Most antidepressants have been associated with it, and usually if they would occur, mostly would occur within the 30 days of starting treatment. And like is not dose related. The common mechanism behind this is the SIADH, which was discussed earlier as well. All patients should taking antidepressants should be observed for the signs of hyponatremia, dizziness, nausea, lethargy, confusion, cramps, and seizures. SSRIs are more likely to cause hyponatremia than the tricyclic antidepressants, comprising most commonly given amitriptyline or mirtazapine, and those older women who are already prescribed with other medications known to reduce plasma sodium are at greater risk for the same. Bleeding. So SSRIs have a high propensity of causing bleeding in patients who are already anemic. Normally, serotonin is released from platelets in response to vascular injury and promotes vasoconstriction and morphological changes in platelets, which cause the platelet aggregation. SSRIs inhibit the SERT receptor responsible for the uptake of serotonin into the platelets. So will deplete the platelet serotonin, reduced ability to form clots, and a subsequent increase in the risk of bleeding will be present. The excessive risk of bleeding is not just confined to upper GI bleeds. Lower GI bleeds risks have also been found to be increased, and uterine bleeds as well. Should be used cautiously in patients with cirrhosis or other risk factors for internal bleeding. Co-prescription of low-dose aspirin at least doubles the risk of GI bleeding associated with SSRIs. And use of SSRIs in perioperative period has been associated with a 20% increase in inpatient mortality. SSRIs increase the risk of GI, cerebral, and perioperative bleeding. If SSRIs use cannot be avoided, it should be monitored closely and prescribe gastroprotective proton pump inhibitors along with it. Now the very important fatal side effect to be noted in patients who are on multiple SSRIs and antidepressants is the serotonin syndrome, which presents as a clinical triad with mental status changes and autonomic hyperactivity and neuromuscular abnormalities. More than the 85% of physicians are unaware about it as a clinical diagnosis. Generally is present in about 14 to 16% of patients who overdose on SSRIs. These are the manifestations associated with it. It can present with midriasis, diaphoresis, agitation, altered bowel movements, autonomic instability with hypertensive clonus, tremor, and hyperreflexia can also be present. Management, like management in the past slides, removal of the precipitating drugs is legally necessary. Provision for supportive care, control of the agitation is present, and administration of 5-HT2 antagonists. Control of hyperthermia. Many cases of serotonin syndrome resolve within 28 hours, 24 hours after the initiation of therapy and discontinuation of the serotonergic drugs. So the treatment, immediate action would be discontinuing the agent, accurate recognition, promptly recognize the condition and discontinue all the serotonergic agents. As the importance is the misdiagnosis, which can cause the worsening of the outcome. Supportive care with stabilizing the vital signs, correct dehydration, oxygen saturation, and correct monitoring. Control agitation with if sedation needed to be given with benzodiazepines helps the patient in delirium as well. And muscle contractions. Benzodiazepines, along with this, should be avoided in patients who have a history of head injury. And hyperthermia should be managed with active cooling measures to be given if needed. Medication management with benzodiazepines described earlier to control agitation, seizures, and muscle stiffness. Serotonin antagonists, cyproheptadine, may be used in moderate to severe cases to block serotonin receptors, but its role has been very limited, with muscle relaxants needed in severe cases. Fitdrenterline may be used to treat the muscle rigidity in severe cases, mostly not present. Severe cases requires the intensive care with intubation and ventilation also needed at times. Muscle paralysis may be required to prevent muscle damage from excessive spasms with monitoring and observation for cardiac changes as well. Monitor renal function and muscle breakdown products can damage the kidneys as well. Now the last class of drug which we'll be talking about, the anti-anxiety and sedatives. It has a dose-dependent action. It's written in a flow form that in the low dose it will cause a sedative effect, then it will cause sleep. At higher doses can also be used in anesthesia, then can induce coma and death as well if overdose is done. The most common thing is to be noted is for benzodiazepines toxicity. The mortality and morbidity just from pure oral benzodiazepine overdose is rare. It generally occurs with concomitant alcohol use as well and use of other sedative hypnotics. IV administration or overdose of ultra short acting benzodiazepines is more likely to result in apnea and death. Elderly individuals and very young persons are more susceptible to CNS depressant effects of benzodiazepine than people in other age groups. IV administration is associated with greater degrees of hypotension than other routes of administration and occasional cardiac and respiratory arrest. So these are the signs and symptoms with which patient can present with dizziness, confusion, drowsiness, unresponsiveness, anxiety and agitation. Blurred vision and nystagmus can be present, slurred speech, ataxia, weakness, hypotension and respiratory depression, and coma as well. Management. Flumazenil is the management of choice, which is a competitive benzodiazepine receptor antagonist and should be used cautiously because it has the potential to precipitate withdrawal, benzodiazepine withdrawal in chronic users, resulting in seizures. So it should be given very slowly. And the flumazenil administration is contraindicated in mixed overdoses, mostly with tricyclic antidepressant use as well, because benzodiazepine reversal can precipitate seizures and cardiac arrhythmias, which are related as a risk factor for tricyclic antidepressants. So these are the dosing. Initial dosing of 0.2 mg IV over 15 seconds. If no response, 0.3 mg IV over next 30 seconds. Repeat dose 0.5 mg IV every minute. And maximum total dose which can be given is 3 mg. And onset is 1 to 2 minutes of the drug and duration for 30 to 60 minutes. Now the last topic with the benzodiazepines withdrawal. Withdrawal is likely to occur after abrupt cessation of the benzodiazepine use or an abrupt reduction in the dose of the benzodiazepine use in dependent patients with withdrawal symptoms which can present as agitation, anxiety, dysphoria, increased awareness of sensory stimulus, perceptual disturbances, depersonalization, confusion, delirium, and seizures. Now the barbiturates toxicity with mostly associated with the use of phenobarbital. Strong physiological dependence may develop over long-term use. Depression of the medullary respiratory centers is the usual cause of death for all sedative hypnotic overdose. It is characterized by increased anxiety, insomnia, CNS excitability, and convulsions. There is no medication prescribed primarily for the overdose with barbiturates, but only supportive treatment is advised. In severe intoxication, patient is comatose, respiration is affected early. Breathing may be either slow, rapid, and shallow. Eventually, blood pressure falls because of the effect of the drug and of hypoxia on medullary vasomotor centers. Depression of cardiac contractility and sympathetic ganglia also contributes. Pulmonary complications are also associated with atelectasis, edema, and bronchopneumonia, and renal failure, which are the fatal complications. Generally, as a management is required for the general supportive measures, hemodialysis is rarely needed, and the use of CNS stimulants is contraindicated because they increase the mortality rate. So, summary. So these are the basic side effects, fatal side effects of the antipsychotics with the neuroleptic malignant syndrome, cardiac arrhythmias, venous thromboembolisms, agranulocytosis, respiratory depression, aspiration, mostly associated with benzodiazepine use, metabolic crisis, severe hyperglycemia, especially with atypical antipsychotics, and stroke and sudden death in elderly patients, which are mostly related with elderly in dementia. So all antipsychotics carry a black box warning for increased mortality in elderly patients with dementia-related psychosis as well. These are the two references, and thank you.
Good afternoon, everyone. Today we have all gathered here to discuss violent and homicidal psychiatric patient in emergency. Hi, I'm Dr. Akash Chaudhary, third year resident in Department of Psychiatry. This is the basic layout that we are going to be presenting to you guys. On 6th, that's today, it's going to be my lecture regarding violent and homicidal psychiatric patient in emergency, followed by emergency resulting from substance withdrawal, followed by delirium and organic mental disorders, and at the end, fatal side effects of psychotropics and management. So this is the basic outline of what we're going to cover today. It's going to be comprising of a brief introduction, definitions, effects of violence, steps of assessment, approach to a patient, treatment, and at the end references. So introduction. Violence and aggression are frequent in mental health setting and can have serious outcomes. Underscoring the need for clear management guidelines, their prevention is complex, shaped by intrinsic factors like personality traits, mental distress and anger issues, as well as extrinsic elements such as environment, staff training, the aggressor's mindset, and the victim's vulnerability. Violence and aggression can be defined as a set of activities that may lead to harm to other persons. It can be expressed in action or words, but the physical damage remains and the purpose is clear. So now we're going to talk about the effects of violence and aggression on individual and those surrounded by them. Staff impact. Staff injuries often occur during patient altercations or when managing unpredictable behavior related to psychiatric symptoms. The staff is the first one who attend the patient who is quite violent. So they don't know how to basically approach a patient who might be aggressive to them. So they lie the victim. Intervening in self-harm or escape attempts can also trigger aggression. Patient impact. Violent patients may face housing issues, social isolation, and reduced support, all of which harm the well-being of the patient. Nobody wants to stay with the patient who is quite violent and aggressive. So nobody wants to give them shelter as well. Family and carer impact. Relatives and carers risk injury during violent episodes and may withdraw support if aggressive persists, especially in community settings. So it's better for us to understand aggression. Staff typically link aggression to mental illnesses, while patients are blamed personal and environmental stressors. Recognizing these views is key to appropriate response and support. So the steps that should be involved while assessing a violent patient. First, assess the seriousness of violence. Is the patient suicidal, homicidal, or violent? Self-protection, is he doing it in the sense of self-protection? Patient might be psychotic, he might be having well-formed delusions, and he might consider you guys being there in the emergency that you are also inspired in a conspiracy. So their flight and fight mechanism kicks in and they might be provoked to harm you. Prevent harm check for vitals, rule out organicity, and in the end manage the patient. Patient risk factors for violence in psychiatric setting. So basically how to assess the risk factor that the patient might become violent. Youth is associated with a higher risk of violent behavior. A prior history of violent acts increases the likelihood of future incidents. If the relatives tell you that the patient has been violent at home as well, to both strangers and the family members, that should ring an alarm inside your mind. Patients who are admitted involuntarily tend to show a higher propensity for violence, as they are not aware that why they have been taken to a mental health care facility. Research findings on gender-related risk have been inconsistent. It doesn't matter if it's a female or a male. The propensity that you might get harmed from a violent patient lies both through the equal sexes. No definitive pattern have been identified regarding the influence of ethnicity. Neither any ethnicity could be more aggressive or less has not yet been established. Schizophrenia is the psychiatric diagnosis most frequently linked to violent behavior, especially during its acute phase. While the illness is setting in, patient might be delusional that people are conspiring against him. They might be trying to harm him. So these are in the acute phase, like the initial onset of the illness. The patient might become aggressive. Substance abuse is a major contributing factor to the risk of violence. The propensity that the patient might attack you is way high when the patient is intoxicated rather than the normal mental state. Most individuals with psychiatric illnesses are not violent. Only a small subset is responsible for a large proportion of violent episodes. This we need to spread it as more often in the community, that the patient, if a psychiatric patient, won't lead to violence. A very small propensity or a small proportion of the people who are mentally or psychiatrically ill resort to violence. Facilities such as psychiatric intensive care units, forensic hospitals, and locked wards, due to the nature of their patient population, report the highest rates of violence. Again, the bias. The patients usually go to a hospital setting where the propensity that the patient, it's basically the Bersonian bias, that if you try to find the patients who are violent, the propensity that the most violent patient will be there in the psychiatry ward because they are segregated in a certain way. Now, this is one of the most important slides, differential diagnosis of a violent behavior. If a patient comes to you and the patient is violent, what usually the practicing physicians fall into praise the patient is violent is irrelevant while talking. First of all, the bulb that clicks in their mind is that he might be a psychiatric patient. So first of all, it's very essential for us to rule out the organicity. Medical causes which might be there, that might be presenting you as the patient has a psychiatric illness, could be a cerebral infarction, cerebral neoplasm, electrolyte imbalances, hepatic disease, hypoglycemia, hypoxia, infection, renal disease, temporal lobe epilepsy, and vitamin deficiencies. Substance-induced, alcoholic intoxication, alcohol withdrawal, stimulant intoxication, stimulant withdrawal, sedative and hypnotic withdrawal, all the intoxicated conditions and the time when the patient is in that withdrawal state might become violent. Then comes the psychiatric antisocial personality disorder, bipolar, obsessive compulsive disorder, delusional disorder, dissociative disorder, and so on. Signs suggesting a medical cause. If the age of the patient is greater than 40 or less than 12 years with no prior psychiatric history, this indicates that the patient might be having some medical cause other than the psychiatric cause. Sudden symptom onset. For example, a patient comes into the triage, 60-year-old woman who has never had a prior history of any psychiatric illness, and the patient comes to you and the relatives tell you कि अभी तक ये एकदम ठीक थे, पिछले 6 या 7 दिन से बड़ी अजीब अजीब बातें कर रहे हैं, इनको भूत दिख रहे हैं, चीजें दिख रही हैं, पर इससे पहले उनकी पुरानी कोई हिस्ट्री ऐसी नहीं रही है. All of a sudden, जो भी symptom acute in onset है, the probability of the patient having an organicity or a medical cause is way high as compared to a psychiatric illness. A psychiatric illness involves insidiously. The onset of acute onset is quite rare. Fluctuating course, symptoms come and symptoms go. The symptoms are not consistent. Another point that points out that the medical cause will be responsible. Visual or olfactory hallucination, damage to the occipital lobe may guide the visual hallucinations of the patient. The most common hallucination that the patient reports in schizophrenia patient is auditory. So if the patient is able to see or visualize things, the cause might be organic. Abnormal vital signs, disorientation or fluctuating disorientation, patient is not oriented to time, place and person, memory issues or recent head injury, all point out the cause of organicity rather than a psychiatric illness. Challenges in evaluation. Patient may be psychotic, mute, agitated or unreliable, making history taking very difficult. It is important to gather collateral information from family, friends, neighbors, therapists, police, medical records or past hospitalization. A good thorough history taking always comes in handy, no matter in whichever department you are currently working in. Recommended medical workup. If medical causes are suspected, conduct physical examination and medical workup. Obtain blood tests, CBC with differential electrocyte, urea, creatinine, liver function test, thyroid function, calcium and toxicology, urine and blood for any substance abuse. Conduct ECG and neuroimaging whenever necessary. NCCT head is always a must. Measure drug levels if on medications like lithium, carbamazepine or valproate, as these drugs have a higher propensity to cause toxicity. Patient might be taking lithium for the mood disorders but present to you as psychotic. This could be due to increased level of lithium inside their blood. Even in initial results are normal but suspicious remains, further evaluation is advised, especially in older adults or those who know with known medical issues. Special population. Elderly patients, especially those with dementia, are prone to behavioral disturbances due to infection, poor nutrition or medication issues. AIDS-related psychiatric emergencies have decreased but still exist, often presented as the 5 signs of infection. Patients with HIV and psychiatric substance use disorder are often termed triply diagnosed and require thorough serological testing. Management. First priority. Ensure the psychiatric emergency services environment is safe for both staff and the patients. Train staff to manage aggression and understand their roles and responsibilities. Adopt non-coercive techniques like offering food, drink, reducing stimulation, and using de-escalation. Make the physical setup safer with measures like one-way mirror observation, security cameras, and posting rules clearly. Improve safety with weapon screening, interview rooms where the patient cannot trap the examiner, enclosed and secure interview places, panic button in each room, code purple 3003 always comes in handy. If you feel your safety comes first as compared to the patient presenting you in the emergency services. So it's all right, it's okay if you feel afraid. If the patient is violent, it's better that you call for help for support and then go on with the further interaction. Staff trained to respond to these emergencies. Approach to handling aggression and violent behavior. The approach to managing aggression and violence depends on the patient's level of awareness and orientation. If the patient is confused or delirious, treatment should follow delirium management protocols first. If the patient is alert and oriented, the following strategies may be used, which comprises of verbal calming techniques, use of restrictive measures, and medication-based interventions. So it's better to first rule out delirium in the patient, treat the underlying cause, and then later on, if still the patient is not oriented, so it's better that the patient stays in the attention of the medicine unit as compared to a psychiatric unit. So de-escalating strategies, what you're supposed to tell the patient and how you're supposed to approach the patient. Effective de-escalation hinges on the clinician's ability to communicate skillfully, which includes conscious control of both verbal and non-verbal cues. Don't act afraid, don't be perplexed after seeing a patient. It comes with regular practice, so it's okay if it takes time. Staff should remain mindful of the factors such as posture, eye contact, voice modulation, and the use of straightforward, unambiguous language. Maintain a position at eye level with the patient, being aware of personal space, and refraining from physical reassurance. Since touch may be misinterpreted as threatening, are all essential. Patient comes to you and you're trying to calm the patient down. You are keeping your hand on his shoulder so that you might establish a rapport, but the patient might perceive it as a threat because he is not able to see your hands. So he might act out as aggressively. Maintaining, when confronted with aggression, the staff member should adopt a calm, solution-oriented stance, portraying themselves not as an enforcer, but a supportive presence willing to listen. You should act as a problem solver. Patient comes to you and patient is quite agitated, tell the patient, okay, we are here to listen to you, not here to restrain you or to enclose you. You are the one who's going to mediate. The goal is to collaborate with the patient using a variety of approaches to guide them towards alternative, less harmful ways of managing their distress. Use verbal de-escalation to reduce tension and avoid escalation. Offering food or drink may help in establishing rapport and calming the patient. Keep a safe distance, at least 2 quick steps, 4 to 6 feet, depending on the situation. And if you don't remember 4 to 6 feet, imagine patient is lying down over the stretcher and create a mental oval around the patient. That is the amount of distance that you should be keeping in mind while talking to an aggressive patient. If the patient is standing, clinician should preferably also stand at the same level. Sit if the patient is sitting. Patient should not see you as an aggressor. If the patient is sitting, pull a chair, sit down with the patient. If the patient is standing, you also come up to his own level. Avoid towering or approaching too quickly. Assume a non-threatening position, example, hand at waist level, or move very slowly. Clinician's posture and de-escalation. Adopting a non-threatening body posture, palms open, no visible syringes, reassure the patient, especially if he is paranoid. Techniques like thinker pose or placing a hand on the cheek can diffuse tension non-verbally. Staff presence and show of force. A show of force, presence of multiple staff security is sometimes needed for uncooperative patient. So again, how open you are and how regularly you've been able to interact with the aggressive patient. It's okay to call for help. Supportive presence of staff conveys that violence is unacceptable but must not feel like intimidation. Should not humiliate or coerce and must aim to ensure safety and cooperation. It's our responsibility and our duty to tell the staff to not make fun of the patient, as the patient might take it as a threat or might act out upon the various visual perceptual cues that he's taking. Confidentiality in life-threatening cases. Written consent is preferred, but in emergencies, example suicidal, homicidal, threats, or inability to communicate, confidentiality may be broken without consent. Emergency takes precedence over privacy. Clinicians should document clearly in such cases. A child comes to you who's quite aggressive and they are saying that please don't tell the family members, and the patient is currently having active suicidal ideation. The privacy goes out of the window in that case. It's better to call the family members and take care of the patient. Pharmacological management of psychiatric emergencies. Pharmacological interventions may be primary or support therapy when patients are unable to cooperate. Benzodiazepine and second generation antipsychotics are commonly used. Lorazepam is often the benzodiazepine of the choice. Lorazepam is the one drug that you should never forget, even if the patient is delirious. 2 mg lorazepam goes a long way. You don't need to think twice. You should go for either Serenase or Phenargan. Lorazepam works with all. As even if the patient is delirious due to some head trauma, it acts centrally but is quite short acting. So 2 mg lorazepam is quite safe to calm down the patient. Always remember, when the patient is aggressive, the aim is to calm down the patient, not sedate him. Never go for midazolam or IV midazolam to just so that the patient falls down. The main purpose of the calming effect of a benzodiazepine is so that we can further carry on with the examination and talk to the patient and the reason for their aggression, rather than keeping the patient out cold. So first we give the oral medication like benzodiazepine, antipsychotics, or a combination of both. If the patient is not cooperating, perinternal medications are advised. Intramuscular is always advised before intravenous. Lorazepam, diazepam, midazolam, olanzapine, or haloperidol. The best combination that is given in our textbooks is a combination of lorazepam and haloperidol. Combination of benzodiazepine and antipsychotics, parenteral, intramuscular only, or other agents. Pharmacological strategies. First line treatment, orally disintegrating or liquid risperidone 2 mg or olanzapine 5 to 2 mg or oral lorazepam. If the patient is refusing to take them, when oral meds aren't suitable due to severity, IM lorazepam 2 mg is used, especially for delirium, substance withdrawal, unknown cause not linked to psychosis. Severe agitation due to psychosis, use IM ziprasidone 20 mg plus possibly IM lorazepam. Second line combination, intramuscular haloperidol 5 mg with intramuscular lorazepam. 8 times out of 10, intramuscular Serenase plus intramuscular lorazepam works like magic. Always keep in mind current physical health and vital signs. Medication should be chosen with a clear understanding of the patient's current health status and potential risks. Medication related factors, concurrent medication, there is a risk of increased sedation, even multiple drugs are used together. Drug interactions, close monitoring is required when combining different medications. Adverse effects, serious side effects such as respiratory depression and cardiac conduction abnormalities must always be considered as they can be life-threatening. Monitoring during rapid tranquilization, sedation should be closely monitored with proper documentation of the event and efforts to identify its cause. Continuous observation and frequent checks of vital signs every 15 to 20 minutes for high-risk patients are recommended. Staff should watch the serious side effects like confusion, abnormal movements, irregular heartbeat, low blood pressure and breathing difficulties. Training in emergency care and the use of flumazenil is essential if the patient ends up over-sedated due to increased dose of intramuscular lorazepam. You are asking your staff member to give him 2 mg of lorazepam and he ends up giving full ampule to a child. Then flumazenil should always be in handy to reverse the side effects of respiratory depression. Before reporting doses, reassess the patient to rule out medical causes. A mental status exam should be done if the patient is calm and cooperative. Now, special population, adults over 60. Excessive sedation or loss of consciousness poses significant risk in frail older adults and should be avoided. Always assess and manage potential physical causes underlying the patient's behavior. Older individuals often exhibit increased sensitivity to medications, responding to lower doses and taking longer to show therapeutic effects. Initiate treatment with lower effective dose and increase gradually only if needed. When oral administration is not feasible, IM injection may be considered but should be used cautiously. IV administration should generally be avoided in this age group. For patients with renal or liver impairment, start with reduced dose and adjust dose slowly. Using smaller increments and extending intervals between dose changes, carefully weigh the risk of falls before prescribing sedative medication. A general rule of thumb, half the dose generally prescribed to an adult. If you are giving 5 mg of Serenase, combined with 4 mg of lorazepam, if the adult or the patient is greater than 65 years old, half the dose automatically. It will go a long way if you are not able to calculate what is the correct step you're supposed to take. So just half the dose. Adolescents age 12 to 17, always evaluate and treat any underlying physical or organic cause contributing to their acute behavioral disturbances. Take into account any existing physical health conditions, neurodevelopmental disorders or substance use as they may influence the presentation. Patients generally who are mentally retarded or intellectually disabled, they respond quite dramatically to the antipsychotics or the sedatives that we usually give. So no matter, even if the patient is around 16 or 17 years old, always go with the half amount of dose as that you will be giving to an older adult. Lower doses are typically appropriate for individuals under 40 kgs or younger than 16 years with careful upward titration if needed. The oral route is preferred if not feasible. IM may be used with caution. IV administration should be avoided whenever possible. So the oral dose, you can start lorazepam from 0.5 mg to 2 mg. IM injection from 0.5 mg to 2 mg. Maximum in 24 hours should not exceed more than 4 mg in children. Haloperidol oral dose start with 2.5 mg. Maximum in 24 hours should not increase more than 15 mg. IM injection dose from 1 mg to 2.5 mg. Maximum for 24 hours 7 to 7.5 mg. Now restraints. Another way to calm down an aggressive patient. Restrictive measures. Use of physical restraint. Under Section 97 of the Mental Health Care Act 2017, physical restraint is permitted only when there is imminent and serious threat to the individual or others and must be authorized by the responsible psychiatrist. Key consideration according to the Act, restraint should be applied only for the shortest duration required. The treating psychiatrist or the medical officer must ensure proper documentation, justification and the method used. If restraint exceeds 24 hours, the nominated representative must be notified. It must not be used as a punishment or due to insufficient staffing. The individual should be restrained in a safe area and kept under continuous medical observation. We also have a restraint form with us which is generally present in every department. So it needs to be updated after every 24 hours if the restraint are lasting for more than 24 hours. And the patient's family mention need to be informed regarding the same. Physical restraint methods. Approach 1. The patient is placed on a bed with limbs gently secured using soft cloth or bandages. Continuous supervision is preferred. If not feasible, the patient must be visually monitored for at least 15 minutes and checked every 15 minutes. Approach 2. In a prone position, arms and legs are fastened to the bedside using cotton bandages, allowing limited movement. Techniques should be adapted to the patient's physical and mental condition. 4-point restraint procedure, a clinical checklist. A team of at least 8 staff members is generally required. 1 staff member should be assigned to each limb and 1 to the head. The total number may vary based on the patient's size and level of agitation. Each limb should be restrained one at a time using broad canvas straps. One upper limb should be secured in the abducted position above the head and the other in the adducted position by the side. The canvas strap should be applied in a way that allows 2 fingers to fit in between the strap and the patient's skin to prevent circulatory issues. And it's also advisable that you keep on changing the position of the limbs as well. Key points in physical restraint training: avoid pressure to neck, thorax, abdomen, back and pelvic area. Prop prone patients up so they can breathe more easily. Make one team member responsible for ensuring that airway and breathing are not compromised. Restrain patients for the shortest period possible. This will depend on access to alternative such seclusions and tranquilization. What are the contraindications for restraint? For the convenience of the staff. Staff does not want to work, they want to sleep all night, they restrain the patient. This is not a call. To punish the patient. If the patient is not listening, patient is again and again coming up to the staff. To punish the patient, you apply the restraints. To accommodate a patient's maladaptive request, another patient is complaining regarding the patient that he's not been sleeping, he's been disturbing all night, and you restrain the patient, that'd be a really bad call. Seclusion. According to the Mental Care Act 2017 in India, seclusion is not allowed. In contrast, some Western guidelines recognize seclusion as a method used in certain cases. It involves confining a person against their will in a room where they are physically prevented from leaving. During this period, the individual is typically monitored every 15 minutes through a window or in the door. These are my references. Thank you.